I'm Peter Block in Orlando at the AHA annual meeting for On the Scene. And it almost seems as though it were still today, but it is now on Monday. And we have probably, I should say, with me is Deepak Bhatt. Forgive me, Deepak.
I
got
think
to introduce
it's me.
you. It is you. And so probably for this whole meeting, the most important trial was the SPRINT trial.
Absolutely.
SPRINT trial, a trial of treatment of hypertension. I'm going to let you just go ahead and talk about it a little bit.
Sure, over 9,000 patients randomized to either a blood pressure target of less than 140 or less than 120. Pretty broad population, lots of older patients, patients with cardiovascular risk who were randomized to these two different targets. Patients with diabetes, prior stroke, heart failure excluded, but still a pretty broad patient population, and the results, I think, were spectacular. The trial was ended early because of a mortality benefit, about a 25% relative risk reduction in mortality, modest in absolute terms, but still a mortality reduction. So I think the trial's a home run. Basically, it showed that being on average 3 antihypertensive instead of 2, that's the numbers in the 2 respective arms, produced that clinical benefit, also reductions in heart failure that were really meaningful. So I think that the trial validates what a lot of us deep down inside have felt for a while, that lower is better if you can get there safely. And there were more side effects, hypotension, syncope, renal failure, or electrolyte abnormalities. But, you know, I think if you're careful, monitoring these patients closely, then the strategy of lower is definitely better.
A couple of comments, though. It was stopped early. Stopping a trial early magnifies the effect. And it's always tricky when you stop a trial early, isn't it? Because you don't have the long-term, if you will, data to support what you've learned early on. That number one, I don't think it makes a lot of difference to what you think about this trial because it does support what we sort of clinically think. The other thing that struck me was, as we were discussing earlier, it had a broad range of patients. This isn't all young patients who were taking their medications assiduously to be sure that they would have a good outcome.
Absolutely. I mean, a large percentage were over the age of 75, so it really does show that even in that older patient, yes, there might be more side effects like syncope, hypotension, can't be cavalier, need to individualize therapy, but in a patient who can tolerate it under careful management, lower is better, even in the older patient. And, you know, the main paper was published in New England Journal of Medicine, but there was an interesting analysis that was also published simultaneously in JACC that shows how many people in the U.S. are potentially eligible based on SPRINT, and it's about 8 million people. It's not a trivial number that these results apply to.
Government-sponsored trial, therefore it will have effect on what you are told about how to take care of hypertensive patients. So you being the practicing docs out there.
Right. Well, I think, you know, it's interesting. There are a lot of parallels. It does seem that what many of us believed in practice for years is actually true. That is, lower is better for LDL, for blood pressure, probably for hemoglobin A1C, assuming you can do it carefully and safely without inducing side effects.
Well, let's get there just to finish up. And that is, remember, we've had some other trials that showed lower is not necessarily better. And in fact, there was this transient thinking that maybe higher is the right way to go. Now we're reversing that again.
Yeah, I think we're reversing back to what we sort of intuitively thought was correct. Again, can't be cavalier and just say everybody's got to be lower, automatic targets. You know, in somebody that's frail, for example, in the SPRINT trial, institutionalized patients, nursing home patients weren't included. So you've got to use some common sense in terms of whom you're applying these targets to. But for somebody that's, you know, young or older and vital, I think these targets are correct. And looking back at the older data, even trials like ACCORD, which were far fewer patients, you know, it looked like there was less stroke there. And when you meta-analyze the data, in general, it seems that lower blood pressures are better.
All right, we're back to lower is better. Thank you, Deepak.
Thank you.